Greetings everyone. This is a video lecture on social work and the health of Canadians. I'd like to thank everybody for their patience. I'm feeling a little bit like this social work zombie after having to redo this video lecture multiple times. So apologies, I understand it's disappeared from the webcast. So I'm redoing it and reposting it in a different format in hopes that we won't have these technical difficulties again. I'd like to start this lecture by giving a few minutes to the definition created by the World Health Organization about the concept of health. This is a definition that's been in use for a number of years, and it really talks or speaks of health as something that's more than just about physical wellness and physical illness. The World Health Organization recognizes health as something that is more holistic, encompassing physical, mental, and social well-being. And so health is something that is important to social workers, and it's something that we should be concerned about when we work with clients. HIC is covering a broad range of topics in this chapter, and so we'll try to touch on a number of these through the PowerPoint presentation. There's a close relationship between income level and quality of health. We know that people who experience lower incomes experience more health problems, and so the relationship between inequality in health is something that social workers need to be concerned with. Even though we have a public health system in Canada, people who have a higher income have better health outcomes than people with lower incomes. This public universal healthcare system in Canada is something that evolved over time. Healthcare in Canada is primarily based on a scientific understanding of health, and we use a medical model scientific approach to funding healthcare. The first medical school in Canada was created in 1824 after the government decided that we would opt for this medical approach to healthcare rather than looking at other forms of healthcare, say for example, naturopathic medicine or Chinese medicine. Concern for the health of immigrants in Canada is something that also stimulated the creation of health services. If you have been to Quebec, you might be familiar with Gros Isle, which was a quarantine station created to help prevent the spread of cholera from Irish immigrants who were arriving in Canada. The British North America Act established particular relationships between federal and provincial governments around delivering healthcare services, relationships that still control and maintain the systems of healthcare that we have today. The effects of the Great Depression and serious health issues that arrived during this period of economic depression and recession are part of the stimulus that created a universal public healthcare system in Canada. But it took a number of years between the end of the Depression, the beginning of the First World War, and changes in attitude about receiving government assistance before we really developed the healthcare system that we enjoy today. Within the text, HIC outlines a number of important issues or events that happened in relationship to this process of developing healthcare. And you'll see that there are some supplemental materials in relationship to this on Blackboard. In 1968, Canada passed legislation that created a comprehensive Medical Care Act that provided both preventative and urgent care services for people across the country. It was provided on the basis of an equal federal-provincial cost-sharing plan, which fell under the CAP system, which we will talk about in future slides, and I believe we talked about in the last set of slides. In the late 1990s and early 2000s, however one says that, there was a lot of talk about the rising cost of healthcare and whether or not healthcare as it existed in Canada could continue to exist. There was the desire to create a new understanding of healthcare, but also to understand what the public's belief was around healthcare. And so the Romano report was released in 2002 after the Romano Commission engaged in interviews and focus groups all across the country to talk about the meaning of healthcare to Canadians. It was very clear from the Romano Report that Canadians generally see healthcare as a Canadian value and as something that is closely linked to Canadian identity. And so there's a strong desire by the vast majority of people to maintain a universal public healthcare system. And so the Romano Report largely reflected this understanding, but also presented a number of recommendations to improve healthcare and to create greater efficiency within the system. The report provided a large number of recommendations, some of which related to short-term activities or outcomes, and others that related to long-term strategies designed to engage in prevention and to, generally speaking, reduce the cost of healthcare in the long term through front-end investments. And so today, we continue with this publicly funded universal healthcare system where we as eligible citizens, and I use the term citizen loosely, are able to receive care in hospitals from private physicians and other healthcare providers like, say, physical therapists or occupational therapists, or in some cases social workers, in order to have a broad range of healthcare needs met. Our public system operates on the basis of a publicly administered system that provides comprehensive care, so care that covers a wide range of health issues, that provides a universal set of services to people based on particular kinds of eligibility. There are certain services that certain people can receive based on their identity. So, for example, there are services that children can receive, like particular inoculations, that adults are not eligible for because once you reach a certain age, these kinds of care activities are no longer helpful. You can also move from place to place, from province to province, and maintain your health care access with some limitations. For example, if I were to move from Ontario to British Columbia, I'd have to establish residency for 3 months in BC before my health care would be covered by British Columbia. Rather, if I received health care in that 3-month period, the province of Ontario would transfer funds to British Columbia to pay for my services. And there is a hope that this universal healthcare service will be accessible to all Canadians. Of course, accessibility in an urban center is very different than accessibility in a rural community. There are a lot of advantages to a public healthcare service. When you purchase services in bulk, you can share costs, and so the cost of healthcare activities can be greatly reduced. So, for example, when the federal government buys large quantities of a medication like, say, Tamiflu, in order to ensure that we have an adequate supply of that medication in the event that we have a major outbreak of the flu, it's much cheaper than if each individual Canadian were to buy their own small stash to maintain at home in case they got the flu. Taxation as a system to finance healthcare is quite an efficient reality, and you've seen in the previous slides the fact that taxation allows for minimal administration around funding, and so there are benefits in terms of administrative costs to developing the service in this way. Because our healthcare services are funded, we can engage in preventative care. So we don't have to make decisions about whether we treat an illness that we're having right now or, say, get an inoculation to prevent us from getting an illness. Now, we all know that not everything is covered. So, for example, if you wanted a hepatitis A vaccine, you'd have to pay for that. But the measles vaccine, for example, is covered by the government. And again, this idea of a single buyer buying multiple supplies and services as a cost-cutting measure can be very effective and efficient. There are a lot of threats to the public health system in Canada. For example, the North American Free Trade Agreement, in some circumstances, sees the universal healthcare system in Canada as a kind of trade subsidy. And so trade agreements could threaten our public health service and force us to privatize some aspects of it. The government has been engaging in small amounts of privatization in the healthcare service, and it's something that Canadians will want to pay attention to. For example, the services that people receive at home, if they're seniors or people with disabilities who are being provided with home care, are often services that are provided by for-profit organizations. So there are care companies, predominantly from the US, who sell PCW services to the provincial governments in order to provide at-home services like, say, bathing or personal care to people in Ontario. And this is a form of privatization. There's also some concern about the need to maintain a comprehensive service, particularly as new medical technologies are developed and people have increased expectations about the kinds of services that they're going to receive when they access public health care. And finally, other forms of contracting out, which result in privatization, are also a concern. Another example is blood services. So for example, there was a time when if you needed to have blood drawn for a test, you'd have to go to a hospital or a public health center to have that blood drawn. Now we can go to a lab, and there are many labs that are located in all kinds of convenient places like the mall, for example, and these are private for-profit companies who are contracted out and receive payment or reimbursement from government for the services that they receive. But remember, in that reimbursement is a profit margin for stockholders and shareholders who benefit from the profit of the company. Community health centers play an important role in providing health care in urban centers. So if you live in Oshawa, for example, or you live in Ajax, both of these centers have community health centers. And these centers provide a wide range of services, for example, services of general practitioners or family doctors. They also engage in health promotion activities and providing services for communities who are marginalized. So for example, at the Oshawa Health Center, there is a focus on care for urban Aboriginal people or urban Indigenous people, and at the present time, the Community Health Center is working on developing a friendship center for Indigenous people in the Durham region. And so the kinds of services that are provided by community health centers are important, and they are part of ensuring that people have access to health care and that health care costs are kept under control, because the people who work in health centers are salaried employees rather than people who bill OHIP on a per patient basis. One of the benefits of a public health system is a commitment by government to really develop an understanding of health and the effect of particular life circumstances on the general population in order to ensure that the health services that are being provided are adequate. Hicks cites the Lalonde Report as an important document that established a holistic understanding of health, a kind of predecessor to what we might understand as the population health model or the social determinants of health. And so this report really spoke to the idea that there was a relationship between both biology and to the living, working, and social conditions that people faced on a day-to-day basis, and that together these phenomena would produce particular health outcomes that could be modified by modifying things like environmental conditions or working conditions. And so this kind of research or investment in scholarship by government is important to ensuring that we continue to use our healthcare dollars efficiently and that Canadians have access to the kinds of resources and supports that they need. This kind of holistic understanding of healthcare really invites social workers to think about the root causes and the context that surround people's health circumstances. This story of Jason, which is taken from the Health Canada website, really reflects this idea that social workers and other healthcare professionals should be concerned with understanding context. This short story sort of presents the idea that there's a connection between the particular infection that Jason has in his leg and the conditions that he lives in. His living conditions are directly related to his parents' employment circumstances. And so when we have high levels of unemployment, high levels of poverty, low levels of quality housing, low levels of safety in the community for kids who are playing in a junkyard, we have negative effects that could potentially result in Jason having a lifelong illness or lifelong disability. And so investing in care for people when they are young, investing in the community, can mean that we reduce our health and social care spending later on. This short story is also a great example of the way in which social workers could use questions in healthcare settings to develop deeper understandings of what's happening for the people we serve. A lot of social workers in Canada work in hospitals. We have a variety of different roles, and discharge planning, as mentioned by Hick, is just one of the things that social workers do. Sometimes we work in outpatient services, ensuring that people have the resources that they need in the community, and sometimes we do assessments like mental health related assessments or other assessments to support people to receive things like supplemental funding. Working in a hospital is great, and I've worked in 2 hospitals as a social worker, one in Toronto and one in Halifax. Hospital work is well paid, the working conditions are good, there's usually an understanding of the needs of patients as being quite diverse, and you get to work as part of an interdisciplinary team, and there are always other people who can back you up. One of the challenges of hospital work, though, is the fact that many hospitals require a graduate degree or an MSW in order to get a job. But there are a number of hospitals in Ontario that do hire social workers who just have a BSW. In more rural communities or communities where there's a shortage of MSWs, like in Hamilton where I live, there are jobs for BSWs. In community outpatient services, there are often jobs for social workers who are doing hospital-based programming but in the community. So for example, working on an ACT team, you may be able to get a job with a BSW rather than an MSW. But an MSW is an important key to opening the door to hospital social work. Social workers in healthcare settings frequently work in interdisciplinary teams, as I already mentioned. So you might find yourself working on a team where you are working with a number of doctors, perhaps a psychiatrist and a family doctor, with psychologists, with occupational therapists, and with nurses. This allows the team to address a person's issues or concerns from a broad base of understanding. Each practitioner brings with them particular knowledges, particular understandings, particular skills and abilities, and so patients, in theory, can be well cared for. One of the challenges with interdisciplinary teams is the potential for conflict, in that with these multiple perspectives can come misunderstandings or disagreements about what is most important and what needs to be done. Within hospitals, there's also very particular issues around power and the relationship between doctors and different healthcare providers. And I'm sure you'll be able to find some research into this if you're interested. Hospice or palliative care work is another area of social work. Social workers frequently work both with patients receiving hospice or palliative care and with families who are dealing with the death of a loved one. The focus of palliative care is on quality of life and ensuring that the patient or the person who is dying can do the things that they want to do to the best of their ability. There's also a focus on pain management rather than on cure or restoration in this kind of medical care. And so social workers may be a part of helping to determine what level of pain a patient is experiencing in order to ensure that they can get the kinds of resources and supports to help them with that pain and to manage their pain well. This is challenging work, but it's also very rewarding work. And there are certainly a number of videos available on YouTube if you're interested in finding out more about hospice care. Social workers frequently work in the area of mental health care, whether in hospital settings, in community-based hospital programs, or in private organizations, private not-for-profit organizations that provide community-based mental health services that still uptake a medical model, for example, the CMHA model. So, social workers need to be concerned with comprehensive understandings of mental health. And of late, there's been a lot of emphasis by governments, federally and provincially, around the importance of mental health to daily functioning, as well as the removal of stigma around issues of mental health. There's a long history of stigma relating to mental health, and again, if you're interested in this issue, you can certainly find lots of resources. Trent has invested some resources in things like public education campaigns around mental health stigma, and so you can probably find bulletin boards or brochures close at hand if you're interested in more information. And social workers would certainly have a role in this kind of public education activity in order to reduce the stigma of mental health or mental health illness. Within the context of mental health, social workers provide a broad range of services, from individual counseling to more community-based activities to do things like, as I've already mentioned, reduce stigma, or to mobilize people who use mental health services to really, advocate for different kinds of services. So any kind of social work that we do in other areas can really be applied to the field of mental health, and Hicks provided us with this short list, but I'm sure that you could find a few other things to add to this list. HIV/AIDS care and AIDS prevention work is another area where social workers are actively involved. And like mental health, there's a very broad range of services and supports that social workers may provide to clients, as well as a number of different indirect social work activities. Again, Hicks provided us with a list, and I've uploaded a couple of videos onto Blackboard that I think really speak to the idea of HIV/AIDS work. In particular, there's a short video by an HIV/AIDS education and prevention worker that I think is a pretty powerful presentation of the complexity of this kind of work. If it's an area you've never thought about, it's something that you might want to consider, because it really does bring together a number of different social work activities under one umbrella of service. Social workers frequently work in the area of addictions, sometimes within the medical context and sometimes within more community-based organizations or agencies. And so, we're concerned with the treatment of addiction. We have new understandings of addiction, and we've reframed addiction to understand it really as a symptom of other issues rather than as the primary issue in and of itself. We also know that it's easier to manufacture different kinds of drugs at home, and so access to dangerous drugs that could potentially harm someone, for example, crystal meth, has also increased the concern and interest in addiction services at the community level. Social workers often work in detox centers or in aftercare treatment programs, as well as in hospital-based inpatient addiction services. Many social workers use a harm reduction approach in which they work with clients on developing an understanding of how to use with the least amount of risk to that person, rather than aiming for an abstinence-based approach where someone completely stops using all substances in order to understand themselves as recovered or in recovery from addiction. There's a lot of literature on the harm reduction approach, and Indigenous or Aboriginal community-based approaches to harm reduction have contributed significantly to this kind of social work practice. Hick makes mention of the BC-based Safe Injection site in the text, and you'll notice that there's a short video on the injection site that has been uploaded to the Blackboard site. It's a short video that really gives an overview of the motivation for creating the site and the way in which the site operates. I think it's worth the time that it takes to watch it, and so I'd highly recommend it for those of you who are interested in the area of addictions. If you're interested in other resources, you can certainly look at some of the resources in Europe, particularly those in Sweden and in the Netherlands, where attitudes towards substance use and addiction are much more socially lenient and socially tolerant than they are in Canada. And so resources and supports around drug use are more attuned to the needs of people who are using, rather than to the kind of historical moral re-education orientation that we've seen in other areas of this course, particularly in historical discussions of British Poor Law. Health for Indigenous Canadians, or healthcare for Indigenous Canadians, is solely the responsibility of the federal government. But we know that for the most part, healthcare services are actually administered at the provincial level. So the federal government often has agreements or exchanges with provincial governments in order to ensure that Aboriginal people or Indigenous people have access to healthcare. But for people living on reserve, there's often a limited access to healthcare services and resources. And so urban or suburban locations that provide service to large numbers of Indigenous people are working towards developing healthcare approaches that are more consistent with the values and beliefs of Indigenous people. Some communities have been more successful than others, and there is still a lot of disrespect experienced by Indigenous people when they access mainstream healthcare services. There are some videos that I've included on Blackboard that help to, well, maybe shed a little bit of light on some of the needs and hopes that Indigenous people have around their healthcare, as well as some success stories around hospitals that have developed respectful ways of engaging with Indigenous people. And so social workers who work in hospital settings have a role to play in ensuring that Indigenous patients receive health care that not only meets the general standard, but also is respectful of their needs. This concludes our brief look at social work and healthcare. I hope this has been useful to you, and again, I apologize for the complications with the video, and hope that you enjoy the rest of the course.